General Hospital. Among her many other achievements, Dr. Kumar has a specific interest in diversity, equity, and inclusion. She serves as the Board of Directors liaison to the Inclusion in Neurocritical Care Committee of the Neurocritical Care Society, and she's the co-chair of the Interdepartmental Equity Subcommittee of Inclusion, Diversity, Anti-Racism Efforts, and Inequity Program in the Department of Neurology. She's also the chair of the Penn Forum for Women Faculty, and she's so many other things that I have left out for the sake of time. But rather than bore you with a list of her achievements, I'll just introduce her to present her really inspirational talk on the impact of current legal rulings on healthcare disparities in medicine and in neurocritical care. Thank you so much for coming.
Thank you, Alex. This is really an honor for me to be here, and I will pull up my slides. All right, can you see my slides?
They're perfect.
Awesome. All right, so I will get started. Thank you for that very warm introduction. I feel like I have many friends at Mount Sinai, and so I'm particularly honored to be here. I will say I have no disclosures, but this, as Alex pointed out, was really inspired, and I was lucky enough to have the Inclusion in Neurocritical Care Committee put me forward for this DEI talk, and so that was the genesis of this. And I welcome feedback and any comments that you may have at the end. But I do have some caveats. So I'm not a lawyer or an ethicist or a journalist, but I am an academic physician and concerned citizen who believes that healthcare providers need to understand the implications of current political climate on patient care, clinical practice, and medical education. Although we're going to talk about some complex subjects, we'll focus today on healthcare disparities and the intersection with neurocritical care. I am truly honored to share my thoughts and personal opinions with you today, and I share them in the spirit of academic discourse. You may disagree with what I have to say or how I say it, and I think that's wonderful. I think the goal of Grand Rounds is to stimulate conversation and promote engagement with our colleagues. But one proviso, a common problem in this area of research and discourse is the lack of standard nomenclature and categorizations regarding race, ethnicity, and gender. So I've tried to include the source data and references for your interest. So today we're going to discuss three seemingly unrelated legal issues in the United States. One, the Supreme Court decision on affirmative action, Students for Fair Admission v. Harvard and the University of North Carolina. Two, the Supreme Court case Dobbs v. Jackson's Women's Health Organization about access to abortion care. And three, the Uniform Determination of Death Act, which underpins brain death determination in the United States. I will argue that these three cases have the potential to both worsen healthcare disparities and significantly affect the practice of neurocritical care. In brief, I'm going to make the case that the loss of affirmative action will worsen healthcare disparities due to reduced representation in the provider workforce and impair the performance of teams in clinical units, research labs, and academic departments. I will posit that the infringements on women's reproductive options will worsen healthcare disparities due to reduced access to prenatal care, compromised shared decision-making in neurocritical care, and will set precedent for criminalization of evidence-based practice. Lastly, I will proffer that the same arguments used to overturn Roe v. Wade may impact the ongoing revision of the Uniform Determination of Death Act, which would have an impact on both neurocritical care and organ transplantation. However, before we can discuss these three legal issues, we must review healthcare disparities. The CDC defines healthcare disparities as preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged populations. So healthcare disparities are differences in and causes of health outcomes amongst different groups. 20 years ago, in 2003, the National Academy of Medicine, then the Institute of Medicine, published Unequal Treatment, shedding light on inequities on care by race. They found that racial and ethnic disparities in healthcare exist because they are associated with worse outcomes are unacceptable. So why do healthcare disparities exist? This slide by the Kaiser Family Foundation depicts the myriad societal factors that drive healthcare disparities, ranging from economic ones to environmental ones to educational ones. Healthcare disparities are assessed by certain metrics, including mortality, life expectancy, healthcare expenditure, and functional limitations. So what evidence of healthcare disparities do I have? Well, I will offer you these 4 examples. In a study of over 80,000 patients from a healthcare claims database, Black and Hispanic patients were less likely to undergo angiography after STEMI. And when angiography was performed, Black and Hispanic patients were less likely to receive a percutaneous coronary intervention when indicated. Data from the NIH indicate that Black people are 4 times more likely to have kidney failure than whites, and infant mortality is twice that for Black neonates compared to white neonates. The COVID-19 pandemic exacerbated long-standing disparities in life expectancy. Although life expectancy dropped for all, for white persons, it dropped from 79 years to 76 years, for Black people, 75 to 71, and for American Indian and Alaska Natives, or AIAN, from 72 years to 65. And in neurocritical care, we know that from the American Stroke Association that Black patients are twice as likely to die from stroke as white patients. Similarly, the CDC has shown that AIAN people are more likely than any other racial group to die from traumatic brain injury and are also less likely to receive follow-up and rehab after their TBI. Living in a disadvantaged neighborhood has been linked to higher rates of diabetes and other healthcare outcomes, including cardiovascular disease and earlier death. The Area Deprivation Index is a measure by the Health Resources and Services Administration. It allows for rankings of neighborhoods by socioeconomic status, including factors such as income, education, employment, and housing quality. Dr. Amy Kind at the University of Wisconsin has created an interactive map with the ADI with resolution down to the US Census defined block. On this map, the least advantaged decile is in crimson. The least advantaged decile is in blue, and the most disadvantaged decile is in crimson. And so you can see that on the West Coast, there's a lot of blue for the least disadvantaged, same with the Northeast. And then in the middle, there's a lot more crimson. In a study from medical ethics at the University of Pennsylvania, the O'Neill Institute for National and Global Health Law at Georgetown, and the Harvard T.H. Chan School of Public Health, the authors compared disadvantage as defined by the ADI by race. And they found that disadvantaged groups are comprised of larger shares of people from racial and ethnic minorities. In this chart, racial groups are arranged from left to right by their share of overall population. So those are the gray bars. Superimposed on the gray bars are the black columns, which show the proportion of each racial group falling under the most disadvantaged quartile using the ADI. You can appreciate that Black and AIN people comprise an outsized proportion of disadvantage when compared to their population share. In addition to societal and systemic factors of healthcare disparities, it should be noted that healthcare disparities may be exacerbated by healthcare providers ourselves. The National Academy report states racial and ethnic minorities tend to receive a lower quality of healthcare than non-minorities, even when access-related factors are controlled for. They found evidence that stereotyping, biases, and uncertainty on the part of healthcare providers all contribute to unequal treatment. This was exemplified in the study published in the New England Journal of Medicine in 1999. In this study, paid actors read from the same script describing symptoms of chest pain. Simulating patients allowed researchers to control for any differences in presentation and factors such as insurance status or EKG findings. They interviewed physicians on their assessment of patients and their prescribed treatment. And these assumptions appeared to influence their actions. Males had a 40% greater odds of being referred to for cardiac cath, and whites had a 40% greater odds of being referred compared to Black patients. In a more recent study of medical students from 2020, researchers found that white students believe that Black patients have thicker skin and fewer nerve endings, resulting in less pain medication recommended to fictional patients. Unfortunately, there are quite a few examples like this in the literature. And so disparities in care reflect long-held false beliefs about marginalized groups. So now that we've established the existence of healthcare disparities, let's talk about the implications of the Supreme Court ruling on affirmative action. So in the Students for Fair Admissions versus Harvard College and Students for Fair Admissions versus the University of North Carolina, the Supreme Court ruled that race-conscious undergraduate admissions policies are unconstitutional. So I hope to make the case that affirmative action increases diversity. Diversity is associated with better outcomes. The Supreme Court ruling threatens diversity in medicine, and therefore this ruling is likely to worsen healthcare disparities. So first, does affirmative action improve diversity? The answer to that is yes. In 1961, John F. Kennedy signed an executive order which compelled government contractors to take affirmative action to realize the national goal of non-discrimination. Between 1966 and 1976, the number of Black students enrolled in colleges and universities quadrupled from 250,000 students to over 1 million students as a result. 20 years later, Californians enacted Proposition 209, a state ban of affirmative action. Within 2 years, there was a 40% drop in Black and Latinx enrollment at UCLA and UC Berkeley. The students that comprised that drop attended less competitive schools, had worse long-term job prospects, and were less likely to attend graduate school or to enter a STEM field. In the chart on the right of the screen, parity or racial and ethnic proportion to the mean is the horizontal line. The further away from the x-axis you are above the line, the more overrepresented the population, and the further below the x-axis, the more underrepresented the population. And you can see here that after the ban, there's a consistent and high overrepresentation of Asian and Pacific Islanders, and there is a significantly reduced number of Hispanic patients, and that reduction was maintained over years. So affirmative action is effective at diversifying schools, but does it improve performance? Not only has it been shown to improve performance, but the effects are consistent across disciplines. From finance to business to science, diversity has been shown to improve outcomes, including the delivery of healthcare and patient outcomes. So what evidence do we have that diversity improves performance? One particularly illustrative example is this McKinsey Group report of hundreds of US Fortune 500 and similar multinational companies. The report assessed the diversity of executive boards, defined as having women and multinationals on them. And they compared it against returns on equity, or ROE, and margins on earnings before interest, or EBIT. They compared the top quartile companies, those with the most diversity, to the lowest quartile. And what they demonstrated was companies with more diverse boards were associated with a greater than 50% return on equity and an increase of an EBIT of 14%. If you limit the analysis to just US companies, diversity conferred a 95% increased return on equity and a nearly 60% increase in the margin on EBIT. Diversity also improves science. In this article for Critical Care Medicine last year, the authors wrote that the advantages of diversity may be particularly pronounced in academic medicine, where new clinicians are trained and the majority of research is performed. The presence of leaders who are underrepresented minorities benefits both trainees and early career faculty, as they can see role models congruent with their own identity. In the research setting, having a diverse group of scientists increases the likelihood of producing higher quality science. So how is that? It's through cognitive diversity. Said another way, it is the search for new information from novel perspectives, and it avoids groupthink. So I've said that diversity improves healthcare outcomes. I mentioned that mortality for Black neonates was twice that of white neonates. Well, if there's racial concordance between the physician and the infant, mortality is halved. This was a study of nearly 2 million births in Florida. And they found not only that when the physician and infant race was concordant, that mortality was reduced, but that this finding was true even in the most complex of patients. There are similar data on gender concordance and cardiovascular outcomes for women. In this study, published in April of this year from JAMA, Black representation in primary care workforces when evaluated by county was associated with a reduction in all-cause mortality for Black people living in that area. So what they did was they studied the number of doctors who were Black in 1,600 counties in 2009, 2014, and 2019. And when they saw increasing Black provider representation, there was a higher life expectancy for patients in that area from having race concordant physicians. Now, this isn't so surprising. We know that minority and URM physicians are more likely to choose primary care specialties to serve patients of their own ethnic group, to serve Medicaid recipients, and in essence, work in the areas of red on the ADI. So in these companion cases, the Students for Fair Admissions versus Harvard College and Students for Fair Admission versus the University of North Carolina, the US Supreme Court held that Harvard and UNC's admissions programs violate the Equal Protection Clause of the 14th Amendment and ruled to significantly restrict race-conscious admissions practices in undergraduate education. The majority opinion wrote that the admissions programs failed to comply with the twin commands of the Equal Protection Clause. One, that race must never be used as a negative, and two, that race must never operate as a stereotype. And therefore, they transitioned from race-conscious admissions to race-neutral ones. Both the AAMC and the American Nurses Association were quick to recognize that although the rulings pertain to undergraduate admissions, this would have grave repercussions in medicine and healthcare. The AAMC writes that the decision demonstrates a lack of understanding of the critical benefits of racial and ethnic diversity in educational settings and a failure to recognize the urgent need to address health inequities in our country. The ANA press release boldly states that the decision signals the continuation of systemic and structural racism, which has inflicted generational trauma in terms of lack of access and academic and professional advancement, and that the decision will impact the necessary pipeline for diversity within the profession to provide culturally competent and equitable healthcare. Another argument for the benefit of diversity comes from the Supreme Court's majority opinion itself, which stated that race-conscious admissions were permissible in some instances, such as the military, which is arguably the same argument for medicine and healthcare. In her dissent, Justice Sotomayor wrote, "The majority does not dispute that some uses of race are constitutionally permissible. Indeed, it agrees that a limited use of race is permissible in some college admissions programs, i.e. military academy, due to potentially distinct interests." In a study from Annals of Internal Medicine last year, Dan Lai of UCLA examined the association between state affirmative action bans and the percentage of URM enrollment in US public medical schools. So to do this, they compared 21 public medical schools in 8 states with bans compared to 32 public medical schools in 24 states without bans between 1985 and 2019. They found that the enrollment of underrepresented students at public medical schools fell from 15% to 10% following state bans, which is about a 35% reduction. And it was the worst for Latinx students. At the University of Florida, Black student enrollment dropped to 6% over 20 years since the ban. And that's 15 percentage points below the state's college age Black population as of 2020. And what you can see in the graph here is that URM enrollment went down after the bans. That's the top line with the Black circles. So in summary, I hope that I've made the case that affirmative action increases diversity. Diversity is associated with better outcomes. The US Supreme Court ruling threatens diversity in medicine, and therefore the ruling is likely to worsen healthcare disparities. And so the takeaways, I think, for patient care are healthcare disparities are likely to worsen in large part, due to a lack of URM representation in the provider workforce. And so for your practice, diversity improves outcomes, be they financial, scientific, ethical, or innovative. And so encouraging and safeguarding diversity is paramount in medical education, research and science, and clinical practice. So now we'll transition to women's reproductive health. The case I intend to make here is that the Dobbs v. Jackson ruling will worsen healthcare disparities and have specific implications for neurocritical care. It will also increase pregnancy-related neurological complications, and it may have impact on future legislation regarding brain death. In Dobbs v. Jackson Women's Health Organization, the US Supreme Court held that the Constitution does not confer a right to abortion, that the prior rulings, Roe v. Wade and Planned Parenthood of Southeastern Pennsylvania versus Casey, are overruled, and that the authority to regulate abortion is returned to the people and their elected representatives, which essentially reverted jurisdiction to the state level. Data from the CDC demonstrate that US maternal mortality is 3 to 12-fold higher than other industrialized nations. You can see that here clearly on this graph. And despite considerable spending of the US GDP on healthcare, maternal mortality is increasing. So in this chart, the blue bar on the left is 2018, and the light maroon bar is 2021. And you can see that over the past few years, maternal mortality is increasing, so even now. And this is disproportionately borne by Black and Brown women. You can see here that the rates almost doubled for non-Hispanic Blacks, from 37% to nearly 70% in 2021. And it is lowest for non-Hispanic whites. And of note, the 1-year increase between 2020 and 2021 for Hispanic women was over 50%. And so although it disproportionately affects Black and Brown women, it cuts across all socioeconomic levels and ages. Adolescents have the highest risk of complications. So to put this in context, a Black mother with a college education is still at 60% greater risk of maternal death than a white or Hispanic woman with less than a high school diploma. On the right of the slide, you'll see Tori Bowie. She was an Olympic gold medalist in excellent physical health, who died at the age of 32 this past June from complications of childbirth. Maternal mortality will only worsen with reduced access to prenatal and contraceptive care. Twice as many Black and Hispanic women obtain care at healthcare clinics. These clinics were largely financed by procedural revenue from abortions performed at the clinic. And the loss of procedural revenue has resulted in closure of many of these clinics. The closure of these clinics has resulted in loss of access, not just for prenatal and contraceptive care, but for all types of care, because many patients of that age get their general medical care at these clinics. You can see in this chart that the graph, the dark blue bars represent the proportion of care received at clinics. And the fraction increases with increased poverty, lack of insurance, in addition to marginalized race. So anti-abortion legislation also reduces care, prenatal care, even in states where it's legal. And this is due to people from displaced jurisdictions seeking care in places where it is legal, and confusion among providers in the states where it's legal about changing laws. This briefing, entitled The Human Rights Crisis, was sent to the UN earlier this year, and it outlines the consequences of restricted access to women's reproductive health care. They outlined cases in which patients with ectopic pregnancies and incomplete miscarriages could not receive appropriate treatment. They documented increasing sepsis mortality and the impact that that had on future fertility. They talked to physicians who said that they have to wait until a mother's life is critical, but that's not really defined well for them. And so they don't know when it's appropriate to intervene. They also documented delays in cancer care for women, because with a prohibition of abortion after 6 and 8 weeks, women who are diagnosed with cancer have to wait until delivery to receive treatment, thus delaying their own oncologic care. In the state of Texas, there was an additional 10,000 live births in the 9 months after restrictions were in place. The chart on the right here shows that the monthly difference of observed to predicted live births in the state of Texas. You can see that after the dotted line in June of 2022, when the Dobbs decision went into effect, there was a stark increase in that difference. But it remains unclear what resources will exist to manage the infants at this increased rate. And it also remains unclear what resources will exist to handle the increase in birth requirements, birthing centers, and providers who can deliver children. 44% of OBGYN residency programs are in states that may ban or have banned abortion. Residents choose to train where abortion is legal so that they can learn the techniques. It also should be noted that the majority of OBGYN residents currently are women, and that 54% of medical students are women. And so state laws may impact their approach to where they want to train. Trainees tend to stay in areas where they train. We know this. And so this might exacerbate care deserts. So if you compare the top map, which is where abortion is restricted, to the area deprivation index, you can actually see a lot of overlap there. So compared to states where abortion is accessible, states that have or plan to ban abortion have fewer maternity care providers, which is a problem if there's going to be increased live births, higher rates of maternal mortality, higher rates of infant death, higher rates of overall death for women of reproductive age, and greater racial inequities across the healthcare system. All right, but you may be wondering, how is this a neurocritical care issue? So for example, Black women have the highest risk of stroke during pregnancy. The stroke subtype that is most common in pregnancy is hemorrhagic stroke, and hemorrhagic stroke, we know, carries a higher case fatality rate. Most of the hemorrhagic strokes are related to pregnancy-related hypertensive disorders, and those need to be managed at prenatal clinics. Therefore, restricted access to women's reproductive health care may worsen neurological complications of pregnancy, especially those with a high case fatality rate. So this was a patient that I cared for over the summer. She was a 20-year-old pregnant woman. She arrived to the ED with no brainstem reflexes and was found to have a twin gestation at 30 weeks. When she first arrived, there was no family present. When we took care of her, we thought, what do we do first? Do we take her to the operating room for a suboccipital craniectomy to relieve the pressure of this large cerebellar hemorrhage? The OBs wanted to deliver her urgently. It was particularly complicated because to do a suboccipital craniectomy, you have to lie the patient prone. And so on a gravid belly, that could be particularly complicated. But it made me think, what if she was only 6 weeks pregnant? What if she was brain dead? What do we do in those circumstances where we don't know? And so in patients with devastating brain injuries, the focus may shift from mother to fetus even before viability, which has been different than our current clinical practice. And if your ICU is like my ICU, this will result in increased moral distress and burnout. So regarding women's reproductive health care, I think for patients, reduced access to abortion care actually reduces access to any and all healthcare for some. Reduced access will also result in increased medical and neurological complications that have significant impact on maternal mortality. The shift of focus from the mother to the fetus, even before gestational viability, may impact maternal health vis-a-vis oncologic care and things like that as well. For you, the provider-patient relationships not only will be compromised, but may be criminalized. And the variability of laws by the state leads to significant confusion in healthcare. And put a pin in that, because we're going to come back to that concept. This all is going to lead to more moral distress and burnout. And on the heels of the COVID pandemic, this is particularly worrisome. Many of you have heard of the labor economist Claudia Goldin, who won the Nobel Prize this year. She attributes much of the gains that women have made in the labor market over the past few decades to the widespread availability of the birth control pill. What the impact of the infringements on women's reproductive health, from prenatal care to abortion to threats to in vitro fertilization, will do to the healthcare labor market, specifically women physicians, nurses, and advanced practice providers in the future, remains to be seen. But it's something that keeps me up at night. Now we'll turn our attention to brain death determination. I will make the case here that the Uniform Determination of Death Act is the basis of state laws and statutes regarding brain death, and it relies upon a distinction between life and death based on neurologic criteria, adherence to accepted medical standards. And it's important to note that brain death has been controversial since its inception. There have been increasing legal challenges which suggest less confidence by the public. The implementation of the UDDA varies from state to state, and there are efforts underway to revise the UDDA, but the current political climate may impact that approach for standardization. The debate about abortion also relies on making a distinction between life and death. The Dobbs v. Jackson rule criminalizes adherence to accepted medical standards. And so this dramatically impacts patient and provider autonomy and has decentralized abortion legislation, reverting jurisdiction back to the states. So it's reasonable to speculate that the Dobbs decision might impact the concept of brain death which attempts to centralize legislation and also concerns patient and physician autonomy. And so if this comes to fruition, this may exacerbate healthcare disparities in access to organs for transplantation. So the Uniform Determination of Death Act was drafted by the Uniform Law Commission in 1980. The Uniform Determination of Death Act has been a model statute for 40 years. It reads, an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. A determination of death must be made in accordance with accepted medical standards. However, many are calling for the law to be updated because, as my intonation implied, the verbiage in the law is not aligned with medical practice. How do we define all functions of the entire brain? Do we have testing that allows us to do that? What are accepted medical standards? Are they the same at your institution as mine? What is irreversible? With advances in science, they're able to reperfuse tissue that allows cellular function to become restored. Is that irreversible? And given these questions, there has been a considerable erosion of public trust. So there's been a call to update the law. They propose a transition from an anatomical approach to a functional approach. So rather than require irreversible cessation of all functions of the entire brain, including the brainstem, the UDDA should require brain injury leading to permanent loss for the capacity of consciousness, the ability to breathe spontaneously, and brainstem reflexes. This definition would better align medical practice with the law. It also would improve confidence of providers in the reliability of accepted medical standards and creates more transparency with patients and the public about what is assessed by the standards. But so why is it important to fix this now? Fundamentally, because the guidelines don't align with the UDDA, and institutional protocols often differ from the guidelines. Even the recent AAN update serves to improve the accepted medical standards. However, if adherence to guidelines is poor, it won't really matter. So taken together, this can place providers in significant legal jeopardy. In addition to clarifying the definition of brain death, the panelists are also considering whether consent is required for an assessment. This is very contentious. How to handle family and religious objections, and how to make the law allow for future changes to medical standards as technology improves. However, the current climate has some clinicians worried that now is not the time to correct the situation. And in fact, when they met over the summer, they could not come to any consensus. And they might be right to be worried. One of the commissioners who was previously in favor of the UDDA has changed his mind, and he does not think that brain death is a biological death. He now argues that even if a person has no chance of recovery, they still have rights. And interestingly, he also serves as general counsel for the anti-abortion organization, the National Right to Life Committee in Washington, D.C. And if you think about his arguments about brain death, they sound very similar to arguments made for abortion, against abortion. In 2019, the AAN published a position statement about accommodation for special requests. And regarding pregnant patients, they state, an ethical analysis should focus on the welfare of the fetus, and that requests by lawful surrogates and loved ones to accommodate the prolonged use of organ-sustaining technology in a brain-dead pregnant woman of any gestational age should be endorsed. However, they also endorse requests by lawful surrogates and loved ones to withdraw organ-sustaining technology if a fetus has not reached a viable gestational age, or if a fetus of any gestational age has sustained a brain injury of substantial magnitude. This will now be defined by state law and not the patient-provider relationship. And so current laws may infringe on the relationship between surrogates and their providers. It should be pointed out that access to organs is another health equity issue. As I mentioned before, Black patients are 4 times more likely to have kidney failure than white. However, they are half as likely to receive a kidney transplant. And when they do receive a transplant, it's not typically from a living donor, which has better outcomes. It's more likely to be from a dead donor or brain dead patient. Therefore, restrictions on brain death determination is a healthcare disparities issue. Changes to how death is determined will also have downstream effects on organ waiting lists, which currently stands at 100,000 people. So in 2021, there was a total of 40,000 organs that were transplanted, including both live and dead donors. The concern is that with restrictions on brain death determination, the waiting list could grow substantially, especially for those from a minority or minoritized group. So regarding patient outcomes, updates to the UDDA may have implications for organ transplantation. And for your practice, similar to the issues with abortion access, the provider-patient relationship may be compromised and even criminalized. Variability by state is confusing and exacerbates concerns about legal jeopardy. And all of this contributes to moral distress and burnout. So in summary, the current legal landscape has direct bearing on medical practice. Diversity improves patient outcomes and teamwork, and plans to safeguard it is critical to ensuring it. The impact of restricted abortion access extends beyond women's reproductive health and is a much larger patient care and health equity issue, and has particular impact on the practice of neurocritical care. The same controversies and complications used to restrict reproductive care may extend to brain death determination. But I can't end on that note. So I'll try to talk about some things that we can do to mitigate against the potential impacts of these healthcare disparities. So regarding affirmative action, really setting diversity as a priority. You can consider distance traveled or locations for pipelines and programs instead of using race. You can employ a holistic review of applicants using structured interviews, rubrics for evaluation. You can increase recruitment and retention of URM faculty using diversity search advisors. And you can diversify research labs and editorial boards. Regarding women's reproductive health, you can critically assess patient outcomes using social determinants of health to see whether there are healthcare disparities at your institution. You can increase access to prenatal care. You can work with your hospital to clarify practices and processes to best prepare for severely brain injured pregnant patients, because they will come. You can work to define what constitutes jeopardy in a woman's life so that you know when you can intervene without confusion. You can collaborate with your ethics services to obtain guidance when it's complicated or challenging cases arise. Regarding brain death determination, you can advocate for uniform institutional policies for brain death determination, and you can ensure training programs for physicians who determine brain death. We can work to credential physicians in brain death determination, regardless of specialty. And you can ensure compliance with the medical standards for brain death determination by physicians. We can increase research that enhances the accuracy of brain death determination, and we can improve professional and public education regarding brain death and improve the discourse in the lay public to be partners to understand it better. If you're interested, the Philadelphia Organ Procurement Organization, or OPO, Gift of Life, has a Gift of Life Institute that worked with the AR/VR firm to create a just-in-time virtual reality brain death determination and family communication platform. If you snap this QR code, you can actually get a link. There's a survey and consideration of participation in a research study, but you can get a link to the training program. And you can do it on your phone. You can do it on an iPad. You don't need to have any special equipment. You can just tilt your phone and pick among certain questions so that you can learn how best to talk to families about brain death, but also how to perform brain death determination. And it is in accordance with the current AAN guidelines. And with that, I will conclude. And thank you very much, Dr. Reynolds, and special thanks to the Inc. Committee of the Neurocritical Care Society. And I'm happy to take any questions.
Thank you so much for that talk. And thank you especially for bringing it back to what we can do. Because sometimes I think a lot of us feel like a little bit of despair. Are there any questions from the audience?
Yeah, this Dr. Gopal, Mount Sinai Morningside, fascinating talk. I mean, it's really amazing. Your goals, are they being achieved? Do we have any data to show that commendable as they are we on the right track?
So, I mean, I think that we're still in the data gathering phase. You know, I'm not sure. I think there's not even a ton of data since well, I mean, it depends on which facet we're talking about. If we're talking about affirmative action, I think that there are efforts. So like in California and Michigan, where there were bans on affirmative action 20 years ago, they implemented new protocols to try to increase diversity, and they have made up a significant amount of the decrement that was lost. But one of the things that's really concerning is that with that sort of fell swoop of cutting off affirmative action, to do those programs costs a lot of money. And so the UC schools have invested a lot of money in improving diversity, not using race, but they have to be much more active and proactive about it. And so it costs taxpayer money to do that, when if you supported affirmative action, you could do that more easily, I think. If you're talking about women's reproductive health, I don't think we're going in the right direction. I'm actually very, very worried. And I think that there are more infringements afoot. And so I think that like the concern I have is that this definition of life and death can really impact lots of areas, not just abortion. I think contraception, is at risk. I think, potentially like in vitro fertilization can be at risk. And that's why I put that slide in about Claudia Golden. It really struck me that the advances that women have made in the workforce have come at some, with some reproductive freedom. And to lose that freedom is going to significantly impact the workforce. And I don't know, there's already talk of a nursing shortage. I know at my institution, hiring nurses and advanced practice providers is not easy. What are we going to do in healthcare if there's a significant fraction of the market that's not available? I think that does worry me. And then with brain death, I mean, they are a hung jury. They are at an impasse. They don't know where to go from here. And the Uniform Law Commission that writes the UDDA are all lawyers. They're advised by some physicians, some in the Neurocritical Care Society, but they're not doctors. So, I think that the court of public opinion has a lot to will impact their decision making a lot. And so, and I think that the area of diversity, we can sort of maybe move, but I don't feel like I have as much control in other spaces.
Yeah, it's always going to be difficult with so many different states having their own different rules and all that to enforce a uniform code. It's hard to imagine. You always mentioned race and gender. What about disparity with socioeconomic groups, substance abuse guys, mental health patients, um, regardless of the race and gender, right? I mean, I feel there is a disparity in providing healthcare or various stuff to these populations also.
Absolutely. I mean, I wasn't limiting sort of the conversation. It was just using the current political climate to sort of take a lens into healthcare disparities. But you're absolutely right. Of course, and I think that this move to assess social determinants of health as part of our, medical practice is really important. I know, I'm 20 years in, and I don't really know the best way to incorporate, how we do this. And so I'm trying to use my role as actually the vice chair for quality to formalize and to codify inclusion of social determinants of health in our standard approach to medical care. But the med students talk a lot about it, but getting trainees and faculty who've been out of medical school for a long time to understand that and incorporate that into their practice is hard, especially when we're already frustrated that there's so many billing and coding things that we have to do. The paperwork part seems the hard part, but I think it really is critical for us to understand because it's really not race, right? It's really like race is the social construct. It's not race that causes the problems. It's more those inequities that you mentioned that cause the problem.
Thank you.
The polarization in politics in the country, I see has reduced trust in the medical establishment. I'm wondering whether we need to become more politically involved in order to regain that trust, because this polarization has gotten to be extreme, which adds to, I think, the complexity of trying to improve and increase diversity.
That's a really important comment. And, I actually attended a talk this morning through the law school where they were talking about how laws impact healthcare. And in the same vein, it was actually the infectious disease group that brought the panel together. And it was because, they wanted to figure out how can they message about vaccines and communicable diseases if there's a erosion of trust and no one believes the science, right? If you vilify the content experts, then how can you get the message out and protect people's health? I think you're spot on with that comment, and I wish I had better insights, but I do think being more vocal is going to be important, and for us as physicians to step into the responsibility and power that we have in society to do good, I think is going to be crucial. One thing that the dean of Georgetown Law, who was present on the panel this morning, said was that in her very limited experience on Capitol Hill, she said when physicians came to Capitol Hill, they were often advocating for themselves and not their patients. She said, maybe I had a very skewed view of my time on the Hill, but she said it was really, it was more, trying to get more for reimbursement than it was for advocating for patients. And I think we have to be mindful of that, or at least the perception that that might be what we are about.
Yeah. How can we be more vocal?
So, I think there's a lot of things. I think, I'm really interested lately. I've been seeing in JAMA and, in the Green Journal and things like that, there are more viewpoint pieces. There are more discussions. I think there's a lot of forums like that people can talk about. I think engaging with your medical societies more and really as a large society, as a medical community coming together and saying, we don't accept gun violence. We don't accept poor drinking water, that maybe we have a way to make comments that I think we would all agree with, that are not political necessarily, but are just about good practice, that I think we all can believe in, that I don't think are particularly controversial, but could have an impact. And I think people will listen to us. But so those are some options. I know one of the OBGYNs that I worked with in Philadelphia as a medical student ended up transitioning her practice into politics. And, I think we all go in to help people, and public policy is a place where maybe we can help broader swaths of people of the community, as opposed to, working in our ICUs. Or both, not one or the other, but potentially both.
Thank you very much. I went to Penn when the ratio of men to women was 10-1. There was separate student governments, separate everything. When I applied
Wow.
to Penn Medical School, I was asked the question, what is the statistics for women in medicine? You all get married and leave. It was so horrible. And I'm so happy that's changed, but there's still so much work to do.
I know it's an extra burden that many carry through their training. We just hosted an event for our clinician educator track faculty, which is our not tenure, but not clinical. It's like a hybrid clinical research model track. And the namesake of the society is Anna Meadows. She's 92. She's a pediatric oncologist, and she identified, the complications of radiation therapy to pediatric cognitive dysfunction. And when after she had 3 kids, she wrote the dean of Harvard Medical School and said, I want to go to medical school, and I think I can do it. And he said, no. He's like, why would we give up a spot for you when we could give it to a man who, has to run a family? And that comment, I think, spurred her on and really was what made her successful. But it's not fair that would have to be the case. And that, we were grateful to women of your generation and you for blazing the trail and allowing us to have the opportunities that we have. So thank you.
Well, we worked to desegregate the fraternities and sororities at Penn.
Wow.
It was incredible. I was very active. I was
That's
president
amazing.
of Women's Student Government. Yeah. And it took
I'm
about
gonna
10 years,
up.
but it finally happened.
Were you there
the men said you take over.
When Phoebe LaBoy was there, or when Drew Faust was there?
Before that. Gaylord Harnwell was the president then, long before.
Wow.
Goes to show
All
you.
right.
But he had an open door. It was the only campus without a Vietnamese student action that was somewhat disruptive, because he had an open door. At least I could walk in as the student body president to Harnwell's office and complain about something or discuss something, and he would listen. So that, I think, was the beginning of the change. So we need men who are confident enough to not feel that women have to be in their place for them to be, quote, superior, unquote, because that's part of it. Men have to have enough self-confidence.
So
And that's
unfortunately, I
happening
have to cut us off because it's past 2:00. But thank you, Dr. Kumar, for a really thought-provoking talk. And I hope we all come away trying to do at least one of the things that you've suggested. And I think, Norma, we need to have you on to do your own talk for us. Thank you so much, everyone, for coming. Thanks, Mona.
Thanks, everyone.